Well, we are lucky enough to have Dr. Thomas Seyfried with us today. Thank you so much for coming on.
Oh, thank you very much. It's a pleasure to be here.
Good. I'm glad. Pleasure's ours. I'd like to start with the rarity of cancer. Over the course of human history, cancer has been a rare disease. Can you speak to how cancer previously was a rare thing in the human world and in the animal kingdom?
Yeah, well, Tim Noakes has a book out that looked at cancer in Wales, um, which is part of the UK, of course. But in the 1800s, uh, in Wales, cancer was not a prominent disorder. More of it was lung involvement, I think, from the coal industry and infections and this kind of thing. And then they reevaluated the population in the 1990s, I believe, late 90s, and cancer had moved into one of the top spots. So clearly, in about 100 years, the disorder in that population group increased significantly. The humanitarian physician Albert Schweitzer also looked at African populations for cancer back in the early 1900s, and he was surprised to see such a low incidence of cancer. As a matter of fact, he looked at thousands and examined. He was a physician examining people for cancer, and they didn't have cancer. They had other things, infections and other kinds of ailments. And he was, this is really remarkable. And the English explorers, I think, in the Inuit population in Canada, also remarked about how infrequent cancer was in these populations. I visited the Thunder Bay Medical School some years ago, which is part of Canada, and they service the Inuits of their country now. And cancer was like one of the major disorders, along with diabetes, heart disease, cardiovascular, the dementia, the whole list of chronic diseases. So clearly, we see a rise in cancer that's clearly associated with the Western civilization, diet, and lifestyle. As soon as that enters your population, brace yourself for a barrage of chronic diseases that come predominantly with food, lack of exercise. And I'm not discounting increases in chemicals in the food and air that we breathe. I think all of this comes together. And some people get cancer, some people get cardiovascular disease, some people get diabetes, and there's an overlap. There's an obesity epidemic. And when you look at animals in the wild, one of my students looked at the wolf, why wolves die predominantly from injuries and infections. I think this is in the wild. And domestic dogs, cancer is the number one killer of domestic dogs. All dogs evolved, were selected from the genome of the wolf. And they're eating the same crap food, no exercise that the rest of us are eating. So if we go back, we have no medical records from our Paleolithic ancestry, which would be anywhere from 50 to 100, 200,000 years ago. Our ancestors were hunter-gatherers. So what would be killing most of those folks would be what was killing most of the animals in the wild, which would be injuries and infections. So their life expectancy would be lower because they didn't have antibiotics and they didn't have orthopedic surgeons to fix their broken bones. Today, we have a whole array of vaccines and antibiotics and things like this. And we have large numbers of highly skilled orthopedic surgeons that can fix broken bones and hips and all the kinds of things that would have debilitated us in the old days. But what's killing us now are chronic diseases, and cancer being number one of the top ones. So it's not a mystery what's going on here. It's our diet and lifestyle that's putting us at risk for all these chronic diseases. And I think it's surprising to me how little understanding most folks have of these concepts. Scientific illiteracy is rampant in our societies. They have very little understanding of anything. I mean, I can't believe how many people still think that the sun revolves around the earth. It's like, what the hell, man? Do you guys not know? They have no clue about biological evolution. I mean, it's just like, wow. And then we're wondering, oh, why are you getting cancer? It's not a mystery. We have a poorly educated, scientifically illiterate population.
Mm.
Um,
I think
so it's not a surprise.
there's a parallel between education and health. Of the consensus view is it's outsourced. My health is outsourced to my doctor. I don't even think about it. My education is outsourced to my school and university. I don't even think about it. And I think that
Yeah.
holds back progress. With the diet and lifestyle piece, and if these problems are exacerbated by poor diet and lifestyle, what is it about poor diet and lifestyle that then leads to cancer?
Okay, so what we know is we have to understand what causes cancer. What is the origin of dysregulated cell growth? That brings us back to understanding why diet and lifestyle are linked to the origin of cancer and other chronic diseases. We can speak specifically about cancer. All cancers that we have studied, all major cancers, which represent over 97%, maybe even more, um, are using energy without oxygen. So this comes from a chronic disruption of oxidative phosphorylation in the mitochondria of cells. Now, let me break it down just a little bit more for you. As I said, Warburg first described that. What we have done is cleared up a lot of the mistakes that Warburg made and the misinterpretation of the cancer field and not fully understanding all of this. But when we look at tumors under the electron microscope, all the major cancers, they have abnormalities in the number and structure of their mitochondria. And when you look at their function, the mitochondrial function is abnormal. Now, it doesn't happen overnight. As Warburg said, if you critically damage your mitochondria, usually the cell will die. But in the case of chronic interruption of oxidative phosphorylation in some population of cells in some tissue, over time, the cell has an opportunity to replace oxidative phosphorylation with the ancient pathways of substrate level phosphorylation. These are fermentation pathways. Now, these are the same pathways that existed in our cells prior to the oxygen entering into the atmosphere 2.5 billion years ago. So in order to understand cancer, you have to understand evolutionary biology. You have to understand that. If you don't understand that, then you cannot understand what I am saying. And believe me, there are very few people that really understand evolutionary biology. So when we look at cancer cells, they're just simply falling back on these ancient fermentation pathways that exist in almost all of our cells, but are very minor. They prepare glucose for the molecule called pyruvate, which is fully oxidized in the mitochondria. But if the mitochondria are not functional, the pyruvate is reduced to lactic acid. And the cells then, in order to replace the efficiency of oxidative phosphorylation, have to have a large logistic supply of fermentable fuels in the microenvironment. Now, you also have to realize that the organelle that controls the destiny of our cells, when to grow, when not to grow, when to remain quiescent, that is the mitochondria. That organelle controls the destiny of our cells. Cancer is cell division out of control. Why is this cell now out of control? Because the organelle that allows it to be under control is corrupted. And the cell is falling back on ancient fermentation pathways because the organelle that's supposed to prevent that is now dysfunctional. And the
So,
cell now requires a large amount of fermentable fuel to maintain a life. But the problem is the life is no longer regulated, it's dysregulated. And you have to realize, based on the work of Albert St. Georgi and others, the alpha period of life on Earth was hypoxic. There was no oxygen in the atmosphere, and all of the single cell organisms at that time grew unbridled proliferation driven by a fermentation metabolism. Cancer is doing nothing more than doing that. and it's driven by a fermentation metabolism. And then, so that's the disease, that's the disorder, a fermentation-driven a group of cells out of control because the organelle that's supposed to control them is no longer capable of doing that.
So our modern lifestyle harms the mitochondria of the cell, which then causes it to flip to an ancient pathway we have, fermentation. Is that some sort of redundant backup mechanism? Much like we have two kidneys, we have two eyes, two ears. Is this
Yeah,
fermentation?
well, it's a default. It's a default mechanism. It's a default mechanism. Like the default state of cells is proliferation, not quiescent. The default, what it falls back on, basically. So oxidative phosphorylation is the newer evolved form of energy. Fermentation was the first form of energy because there was no oxygen. So cancer cells can live without oxygen. We've tested it ourselves. Let me give you an example. We can grow cancer cells in extremely oxygen depleted environments, extreme hypoxia, and they grow fine. But the one that everybody should know about is cyanide. Cyanide is a poison that kills you real quick. What cyanide does is it binds to the cytochrome C oxidase, shuts down the electron transport chain, not allowing oxygen to accept electrons, and we die. We die fast from cyanide. Cancer cells can live in cyanide because they don't use oxygen as a form of energy. So cancer cells, we published this in our big paper from last week. We clearly showed in cyanide and hypoxia, cancer cells are still making energy, ATP, despite the fact that they have no oxygen and they're in presence of cyanide. That clearly tells us that these damn cells are fermenting to stay alive. So how do you kill them? You have to take away the fermentation fuels. And that's the way you kill cancer. You transition the whole body to nutritional ketosis, and then you come in and simultaneously target the two fermentable fuels. And this then puts us on the path for health and recovery. Yes, diet and lifestyle will damage mitochondria in some population of cells in some organ, and you end up with cancer. You can have systemic inflammation that comes from diabetes and obesity, and systemic inflammation damages mitochondria in some population of cells. Intermittent hypoxia, chemical carcinogens, oncogenic viruses, radiation. Any of those exposures over chronic time will damage oxidative phosphorylation, leading to a compensatory fermentation. So this again, we connected all of the dots in this whole thing. We have connected all of the dots, how cancer comes, how it starts, what it goes through, and how it kills you. Okay, most of the time, what's killing you about 50% of the time is the treatments they're using to manage the cancer rather than the cancer itself. It's one of the great tragedies of medicine.
Yes, I mean, I've got some questions around what standard of care does to metabolic health down the line, but just before we get there, I'd love to sort of go back upstream. So we have dysregulation of the mitochondria, which causes this switch to fermentation. You get a cancerous cell. What would the consensus view say to what you just said?
Well, they think cancer is a genetic disease. The consensus view is that cancer is a genetic disease, and all of the mitochondrial abnormalities must be coming from some gene mutations. What we and others have shown clearly is that when you damage the mitochondria, or the mitochondria becomes inefficient in using oxygen, it throws out these radicals, these oxygen radicals, the anionic, the superoxide, and all these kinds of things. They're carcinogenic and mutagenic. So the mutations in the nucleus are actually downstream effects of the damage to the oxidative phosphorylation system. So, and this is a very bitter pill for the field to swallow, that the mutations are really not the cause, they're the effects of this. And we have a problem. It's part of us being human. Human nature rejects when the brain has been indoctrinated to think a certain way about a situation. It often is no longer capable of rational thinking. Religion is like this. When people become indoctrinated into a particular religion, they would rather die than change their religion because the brain has been so molded and indoctrinated. You can't think anything other than what you've been brainwashed to think. And you have that. And then you have also, you have confirmation bias, where because everybody says it must be this way, it has to be that way. So you have ideological dogmatic indoctrination together with confirmation bias, and those two together uh, make the brain incapable of either understanding or accepting what I'm saying. Even when they see the data, they can't accept it. So
Hmm.
and eventually you have to have it replaced, because right now in the United States we have 1,700 people a day dying from cancer. That's about 70 people per hour. So we're going to let an ideological dogma stop us from helping these poor, suffering people. So what are we going to say to these guys, these poor people? I'm sorry, we cannot treat you with metabolic therapy because of confirmation bias and an ideological dogma. That
Mm.
cancer is a genetic disease, so we have to radiate and poison you to make you healthy and do all these medieval kinds of treatments because we cannot accept the fact that cancer is something other than what we thought it was.
Yeah.
It's one of the great tragedies of the times.
It's really something. The late great Charlie Munger has a line on, or he's got two lines that come to mind of the human mind works like a human egg. When a sperm gets in it, it shuts off, right? And I feel like it's the same with these
Yeah.
ideas. When you get these grand narratives in, they shut off to anything else. And the other line he had, which is relevant to our discussion here, is it's super hard to have a non-consensus view in the world and be there touting this when the herd is going the other way, and it takes a special amount of gumption to do that. I know you've been championing this for years, right? And you've been met with a load of pushback, and now you've been proved right.
Yeah.
How have you
Well, they'd
how have you
ignore
sort
it.
of
I don't think they give us pushback. I think both. This is what they always do. They ignore it. They just don't discuss it. And then when you talk to people, oh, they say, it's not right. But I said, have you looked at and read the literature? Have you actually looked at the data? Oh, no, no. I just go with what everybody says. Okay. So, and we're still writing enormous papers published in top journals, hunting for the genes that cause cancer. This is a futile effort. This is absurd to do this. And they always grab, if you look at these papers, they've got like 50 authors on the paper hunting for some damn gene that doesn't exist. So we have found papers in the scientific literature that show some cancers have no mutations. They've been looking. So the somatic mutation theory of cancer, this is the current theory of cancer, is cancer is caused by mutations in the nucleus. These are called somatic mutations. Okay, so they cause the cancer. So we have found papers where there's no mutations, and it's very interesting. The authors of those papers even ignore their own findings. You would think that if you saw a tumor with no mutations, you'd have to say, "Whoa, we should discuss this a little bit more in light of our current theory." No, all those papers ignored it. They didn't say anything about the theory under which they're working. So then they reclassified mutations, realizing that some of them don't do anything and they're just there. But the really important ones are the so called driver mutations. So this was pointed out by Dr. Vogelstein at the Johns Hopkins that we have these other kinds of mutations that are really the ones that lead to dysregulated growth, and they're called drivers as opposed to passengers. Well, we have different now categories of mutations. So the new findings coming out of the scientific literature over the last few years is that our normal cells are full of these driver mutations, even in the P53. Everybody loves P53, this, T, P53 cytochrome C oxidase synthase. It's they're always like, oh, P53, P53. We have dozens of mutations in our P53 genes in normal tissues that have no dysregulated cell growth. So how you explain this? How you explain cancers that have no mutations and normal cells loaded with driver mutations that don't have dysregulated growth? And then you throw in the nuclear mitochondrial transfer experiments on top of all this, showing that the nucleus of a tumor cell placed into a normal cytoplasm has regulated growth. And if I take the nucleus of a normal cell and put it into a tumor cytoplasm, it has dysregulated growth. All of this evidence says it can't be a genetic disease. So what are you doing? Why don't you read the literature? Why don't you understand this? And people say,
well,
well, If it were important, people would have repeated it. I said, it's been repeated dozens and dozens of times. You just choose not to acknowledge it. What are you going to do? It's like
Yeah.
grab the guy's head and smash his face into the data and say, listen, read it, jackass, and you'll come to understand what's going on here. You know,
Definitely.
I mean,
I
it's really
agree.
frustrating. It's amazing. And then when they realize it's only a matter of time, they're going to realize what I'm saying, and they're going to look at the data. Oh yeah, it was obvious all along. Oh yeah, right. Well, I'm telling you, it wasn't obvious all along.
Yeah. What is it? The stars look obvious in hindsight, right?
Yeah.
But what
Oh
would you
yeah.
say to people? What would you say to people who are concerned or have been told about the BRCA gene and breast cancer, and it's seen as a bit of a death sentence? How does the metabolic theory of cancer reframe the BRCA mutation, if at all?
Well, the BRCA mutation, when you look at all the those are germline. Those are germline mutations. Now they're not somatic mutations.
Ah,
Somatic mutations are not linked to the germline. Then you have germline risk factors. They're called risk factors, genetic germline risk factors. When you look at BRCA1, what does BRCA1 do? It damages the efficiency of the mitochondria. So clearly it's linked. The Li-Fraumeni, which is the P53 germline mutation, that's about 90% penetrant, meaning 90% of the people that have that gene will go on to develop some form of cancer in their lifetime, but 10% don't. No germline mutation is 100% penetrant, meaning it's a risk factor. It's what we have, but no cancer has been found with normal number, structure, and function of mitochondria. So the mitochondria is the prime cause of all cancers, but that can happen from germline mutations like BRCA. It can happen from P53 retinoblastoma. There's a whole slug of these germline risk factors. But if you know that all of them in one way or another damage oxidative phosphorylation, leading to a compensatory substrate level phosphorylation, we know how to change our diet and lifestyle to reduce the risk of those cancers. Now, like in the case of the actress Angelina Jolie, she had her breasts and ovaries removed or something as a prophylactic. And other women do the same thing. And they feel that if I cut off the organs that are going to lead to this, but that doesn't guarantee that there won't be other parts of your body that later on develop. So if you understand that it's a mitochondrial metabolic disease, and if you keep your mitochondria healthy, the probability of getting cancer is significantly reduced, then you might want to embrace a metabolic lifestyle to reduce the risk rather than have yourself surgically mutilated. There's choices. People have choices when they understand the facts and the data. They can make choices, and that's the thing. Okay, you can still be surgically mutilated and still go on the metabolic therapy. I mean, there's a lot of variations back and forth for this whole thing, but at least people should know what the hell is going on, so they can make
mm.
an informed choice about their plans.
Okay, so it's not a genetic disease; it's a disease of the mitochondria and the metabolism of the cell. How does that How does that change our approach of dealing with cancer as it relates to how we cut off its fuel?
Well, I mean, we have two things here. The interesting thing about metabolic therapy and recognizing cancer as a mitochondrial metabolic disease is that not only can you use an approach to prevent cancer, so if you keep your mitochondria healthy with diet and lifestyle changes, you can significantly reduce the risk of getting cancer. But let's be honest, most members of our Western societies, regardless of where they're in the UK, the United States, Germany, Japan, most people roll the dice and say, "Well, I'll deal with it when I get it." So that's what most people have to deal with is when they're finally diagnosed with cancer. How do they manage the cancer? So how do they manage dysregulated cell growth? And that big paper we came out with last week fleshes out in a very great detail what options we have to manage cancer when we get it. It was based on our Press Pulse therapeutic strategy. I wrote the Press Pulse therapeutic strategy with some clinician colleagues and Dominic D'Agostino. So that was the framework. It wasn't fleshed out. It was the scientific framework for what you would need to do to manage cancer. But now we have a much more fleshed out protocol for doing this, and there's many options. But clearly, if the tumor cell can't grow without fermentation metabolism, then the strategy is to restrict the availability of the fuels driving the fermentation metabolism, and that becomes the sugar glucose and the amino acid glutamine. As I said, we can press down glutamine with diets, and we have to pulse correction. We can press down glucose, and we can pulse the glutamine. But we do this when the body is transitioned over to nutritional ketosis, therapeutic ketosis. And we also built here at Boston College the glucose ketone index calculator, which has now been put into these devices that will allow people to know when they're in nutritional ketosis quantitatively. So there's no guesswork on this. And then you come in with drugs that will target glutamine while the body is in nutritional ketosis with low glucose elevated ketones. And the cutting edge right now is dosage, timing, and scheduling. We have not yet perfected all of the ways in which we can dose, time, and schedule the different parts of metabolic therapies. That's the future right now. But we also don't exclude parts of the standards of care. We can significantly reduce toxicity of radiation and chemo when you're in nutritional ketosis. We can actually lower dosages significantly and still maintain some therapeutic efficacy of these toxic drugs. In particular, immunotherapies. Everybody's jumping up and down about these immunotherapies. They're based on the somatic mutation theory. So by themselves, they will never be optimal for managing most cancers. However, it's very interesting. They say, well, immunotherapies can't work well on solid tumors because of the acidification in the tumor microenvironment. So this. Let me tell you, that's how crazy it is. So what's causing the acidification in the microenvironment is the waste products of glucose and glutamine fermentation. The waste products are lactic acid and succinic acid. These are the acidified waste products of the tumor cells. And everybody's trying to figure out how we break through the acidification of the microenvironment to allow immunotherapies to work. For Christ's sake, pull out the glucose and glutamine, and now your immunotherapies will probably have a much greater effect. So it's like, I don't understand. Don't they read the literature? Don't they understand what the hell is going on here? I mean, we can make all of these approaches for cancer so much more effective and efficient if they simply understand this is a mitochondrial metabolic disease driven by a fermentation metabolism. It's unbelievable.
So I'll tell you what's going on here in the UK, and you probably know it already. But so if someone has cancer in the UK, they would, even if they've read the papers, they trust the judgment of the doctor. If they're not medically trained, they trust the judgment of the doctor over their own ability to read the paper if they're not from a scientific background. So they could be well-intentioned and read on all the literature, but they go into an oncology ward and say, okay, I appreciate you put me on chemo and radio for my cancer I have. I want to implement a ketogenic diet. I want to do the pulse press strategy. I've figured out a way to get some glutamine blockers. What do you think? And they're met with a response which is completely negative because it's, I don't recommend that, hasn't been studied, or I have no idea what you're talking about. What do you say to people who are in that situation?
Well, it's like the blind leading the blind, right? I mean, you go to it's terrible, right? You go to the guy who was supposed to know he has no clue, and it's really embarrassing. And but that has to change. You have to educate these guys. They're not stupid people. They just lack knowledge. So obviously they got to a position in their life where they think they know something. And in many parts of medicine, that's true. I mean, as I said, orthopedic medicine and cardiovascular, heart replacements, all this kind of stuff. I mean, this is unbelievable stuff. But when it comes to cancer, they're in the Stone Age. They have no clue what's going on. So they have to be re-educated. And the patients have to be knowledgeable as well, because mitochondrial metabolic therapy requires a very strong participation of the patient. So the patient really needs to know what's going on and be compliant with the recommendations of the oncologist. But if the oncologist has no clue what's going on, it's a very frustrating situation, because sometimes the patients know more than the oncologist. The patients. So what we do is, eventually it's going to have to come. But like the patient just brings in the plan and says, "Here, give this to you. You give me the the glutamine targeting drugs at this dosage. You're telling, but
Mm.
it would be more important for the oncologist to know what dosage and timing and scheduling he should do. Why should the patient have to tell the professional what to do?
Yes.
So and this is the great tragedy. The problem is the poor guys all over the world. I've never seen anything like it in India, China, Japan, Germany, UK, United States, Brazil. They're all doing the same thing. They have no clue what's causing cancer, how it's managed, or anything. So we have to have I don't know, how would we do this? We have to retrain. We have to re-educate. Bottom line is there's a tremendous desire on the part of the patients to have this because they're being slaughtered with the current therapies. They're being brutalized. I mean, even the guys who ran the Spanish Inquisition would be impressed on how we torture cancer patients. This is just, the hair falls out, the gums are bleeding, blowing your microbiome to pieces. I mean, this is nuts. You don't have to do all this stuff to get managed cancer. Yet this is what we're doing.
Okay, so for where, to someone listening to this who's not familiar with the harms of standard of care, where is the standard of care correct and what are they doing right? And then what are the problems and downsides of standard of care?
Well, I mean, it's remarkable. I always find it absolutely astonishing that some people, human beings, can be brutalized, poisoned and irradiated and surgically mutilated and still survive. And we have, well, the system will say, well, we have millions of cancer survivors that have been cured by the standards of care. And that's true. But many, many, many of these folks pay a significant price for that management. They have neuropsychiatric problems, digestive problems, hormonal problems, bone density problems, cardiovascular problems. You go right down the list. And most of them don't live a full life. They die later on from some other collateral damage from whatever they've been taking. When we do metabolic therapy, these people that do it correctly, they get much healthier. They all organs in their body start to perform at a higher physiological level, because we're using ketones, which is a super fuel that allows the cells to gain energy. The delta G prime ATP hydrolysis is much more effective. We produce fewer radicals. We make mitochondria healthy in all the normal cells of our body while we're degrading the tumor. I mean, this is a win-win situation all around. Now, but we also know that some parts of the standard of care can be significantly improved and made less toxic by dovetailing it with metabolic therapy. So clearly, the field is going to have to readjust its entire way of doing business if we want to keep people healthy and managed. And don't forget, we don't ever claim cure. We just claim effective management, non-toxic management. Who can claim we're going to cure cancer? You don't know. Okay, they say you've been cancer-free for 5 years, but then at 5.5 years, the tumor returns. So you were never really cured, even using standards of care. Now, some people do. How would you know? If you die at 98 years old when you had cancer at 35 and you died from a heart attack, then obviously you probably were cured from cancer. But we don't know that. We just like to know that we have a disorder that was previously minimally managed with toxicity. Now we might be able to manage it better without toxicity and lead to an improved overall survival, not this progression-free survival. What they do is they approve drugs based on progression-free survival, which means that you give the drug and it looks like the tumor is responding really well, but you don't live much longer. What the hell is that? You want to make sure overall survival. Show me a guy, like, for example, glioblastoma. Almost everybody is dead within 3 years. Almost. Every now and then you get a rare survivor. It makes it to 5 years. If we make 5 years the average survival for glioblastoma, that changes the pattern completely. So then you're on the right track. And this is what our plan is, not only for glioblastoma, but for all these different horrific metastatic cancers.
Standard of care chemo and radio specifically, I assume could harm the mitochondria of the cell, which could lead to more cancer down the line if they beat their first cancer. They've harmed the mitochondria through the standard of care. Is there an argument, if that's true, is there an argument that being on in a ketogenic state, which is good for your mitochondria anyway, would offset the negative damages of standard of care?
Well, I think so. The problem is we need to do those kinds of experiments, and they're currently not allowed to be done at clinical centers right now. So you would have, for example, you'd have standard of care. One population of people would get standard of care, which is what everybody basically gets. Then you get standard of care with metabolic therapy, and then you get metabolic therapy without standard of care. So you have three different groups, and then you'd be able to clearly determine to what extent these would be effective. Now, we are able to do, in glioblastoma, we're able to do we do standard of care first, and then the tumor invariably recurs, and then they're allowed to do add on a metabolic therapy, ketogenic metabolic, but never the way we've designed it. No one has ever done a clinical trial the way we think it should be done. And that's our big paper from last week. That tells you exactly how you should do a clinical trial. The problem is it's threatening. If it works, what happens if these things work? You're going to have to change the whole design of what we do for cancer. But God forbid anybody wants to do the three groups, and we turn out that the metabolic therapy by itself is superior to the standard of care, and even the standard of care with metabolic therapy. What's that going to say? Who the hell wants to do standard of care anymore? But I think it all could be worked out. I mean, don't forget, we're at the tip of the spear here at Boston College. We're the ones that did all this, and we're working it out all the time. We have a very comprehensive preclinical system. We test all this preclinically first, and we only use natural models. We don't use these genetically engineered things. They make all these animal models for cancer. The cancer cells are genetically engineered. The mouse is genetically engineered. I mean, it's just like, what the hell are you doing? Use natural tumors that arose naturally in those hosts. And then you can design and perfect what you need to do for dosage, timing, and scheduling. And then you can bring that into the clinic and modify preclinical, clinical, back and forth, and perfect the system so you know what's going to be maximally effective for the cancer patients.
I think I read on my prep for this where if you're trying to naturally induce cancer in a mouse to then study it, you were trying to do this, but you were calorie restricting the mice, and it was very hard to actually implement some sort of cancer in the mice. If I read that right?
Well, there's several. I've worked on this. We developed natural models of brain cancer and metastatic cancer. Most of these arose naturally in this one strain of mouse. Now, I also made a lot of models putting chemical carcinogens into the brain of mice, and then you could get tumors that arose. None of these tumors that I ever made in the brain were metastatic. They were highly angiogenic. They were not metastatic, highly invasive. But then we discovered the VM-M3 coming out of the VM Dickerson strain of mouse out of Edinburgh, Scotland. They sent us some mice. So we started to see these spontaneous tumors, brain cancer tumors coming out of these mice, spontaneous. We didn't do anything to them. They just developed naturally. And then we characterized the cell in the tumor. And it turned out to be a macrophage, a microglial type cell. And then we went and did a big study on all human cancers. And we found out that all major human cancers have characteristics of macrophages or microglia, which is a cell that can spread around your body. So we now know the biology of metastasis, which is the ultimate killer of most people. We know what the cell is. We know the biology of the cell. So what I did is I went back and I said, okay, let's further evaluate the biology of the macrophage. And there's a couple of guys at Oxford there, the Newscombs, who have done their work actually clued us to what we need to do to manage metastatic cancer. You can believe it. So they interrogated macrophages and found out what they eat. What is the fuels that drive macrophage biology? And it turns out to be glutamine. So glutamine is a major fuel for macrophages. So what we did was we said, well, if all metastatic cancers have some characteristics of macrophage, Warburg clearly showed, and everybody knows glucose is already a major fuel. But the glutamine came because we understood that macrophages, which are the origin of metastatic cancer, need the glutamine. So that's why we can manage all these cancers, whether it's a brain tumor, colon tumor, breast tumor. They're all macrophage. They're all macrophage biology. So now you know how to kill them. And but if you think it's a genetic disease, then you don't even listen to what I'm saying. So you're out on left field somewhere.
So with it perfectly segues into the pulse section of the pulse press methodology. So the press is the continuous state in a ketogenic diet, right? Which we'll get to afterwards. I'd love to explore. But the pulse. Firstly, why the need to pulse glutamine inhibitors, and secondly,
I think first of all, the press. It's not just ketogenic diet. It's the state of nutritional ketosis. You can get into nutritional ketosis with Mediterranean diets, with carnivore diets, with vegan diets. But it's hard with vegan diets, vegetarians and that kind of stuff. Pescatarian diets. Whatever you get your GKI down. I don't give a damn what you eat. People, can I eat this? Seyfried says you can't. I don't. Seyfried says you eat whatever the hell you want as long as you can keep your GKI down. And then people will come to know they're all different from each other. What you might eat might be somebody else can't eat that or whatever. It doesn't say what should I eat. You really want to know? Don't eat anything. Just drink water. Get your GKI.
So for those who
people say, I can't do that. Okay, then you throw the dice out.
Yeah,
it's hard.
So for those who don't know,
I'm not saying this is easy stuff.
No, it's super hard. And GKI is a glucose ketone index, which you developed, which is taking, if my understanding, it's a ratio between your blood levels of beta hydroxybutyrate and contrasted with your blood levels of glucose. Is that right?
Yeah. It's in millimolar, so you can use the same units to make the division. And when you get down into the like my friend Dominic D'Agostino, he's always in a state of nutritional ketosis. He lives in that zone. That was our ancestor. All of our ancestors during the Paleolithic period were always in nutritional ketosis. They didn't have delicatessens on every corner. They weren't eating sugar-filled donuts. They were very active people. Nutritional ketosis is our natural state. This is our natural state. This is who we are as a biology. So not being in ketosis is an abnormal state. We made the abnormal to be normal. We made the abnormal, and now we're suffering from all these chronic diseases as the result of it. So
I was going to ask you,
but so you get your body into nutritional ketosis, and then you pulse the glutamine targeting, and we know, as the Newscomb said, the glutamine is an essential nutrient for macrophages and the gut and the urea cycle and all these very important physiological conditions in our body. When people are burned, you have to give them high doses of glutamine because the macrophages kill the bacteria that enter into our system. We have a powerful immune system that will kill bacteria, and that's those macrophages that kill the entering bacteria or wounds or this kind of thing need the glutamine. So you have to be very, very careful. So if you know your metastatic tumor cell, which is an immune cell, a macrophage or a leukocyte of one of these types, they know that tumor cell needs the glutamine as much as the normal gut needs the glutamine, as much as our normal immune system need the glutamine. So what we find is that when we use glutamine targeting drugs, they kill cancer cells, but they paralyze the immune system. They don't kill the immune system, they just paralyze it. So if you kill a lot of cancer cells, one of the functions of our M2 macrophages, one of the populations, is to pick up dead cells and gobble them up and get rid of the dead cells in the microenvironment. You can't let a bunch of dead cancer cells hang around. You need an active immune system to come in and clean up the mess. So you have to pulse. You cannot continually use glutamine targeting drugs. Yes, you'll kill tumor cells, but you'll also paralyze our own immune system and screw up our gut and our urea cycle. You'll do a lot of other physiological changes. So that's why dosage, timing, and scheduling is what is the cutting edge of cancer research right now. For me, I don't know what the rest of the world is doing. For them, they're out on left field somewhere. So
So how
so
is
um, let me just say that what I've just said is not what we call sexy science. Wow, this is sexy. Dosage, timing, and scheduling. No, it's not. It gets the job done, but it ain't sexy.
Mm. Well, who cares, right? If it gets the job done. How is your how you invented the press pulse protocol with your colleagues, as you allude to, and then your most recent paper as well is it shows the implementation of it with specific glioblastomas. How has the press pulse protocol changed since you developed it, and what is this leading edge you just alluded to there with regards to dosage, timing, and scheduling?
Well, press pulse hasn't really changed. We know what we do because we have to press glucose down, which is not toxic. It was just different ways to do it. What we're learning is there's different strategies to do what the press pulse. You have to realize where did this come from in the first place? Where did we get the idea of press? This comes from the area of paleobiology. Okay, during the history of our Earth, we've had massive extinctions of organisms over the eons. Okay, and this didn't happen by any one event. It happened by a combination of two events. There was a chronic stress on populations from some change in the environment, followed by an acute pulse like a meteor strike or in a series of many volcanoes going off at similar time. And that led to mass extinction of organisms on the history of our Earth. So we just took the same concept and put it into managing cancer. So you press down and
Mm.
make a stress on the whole body, putting the cancer cells at a competitive disadvantage, and then you come in and you give them the final shot in the head with the glutamine targeting. And but it has to be done very strategically, and the ways that we're going to do this is going to be really nifty and interesting, because there's so many different ways we use parasite medications. It turns out parasites and cancer cells use common metabolic pathways to get energy. So we have a whole slug of these different drugs that could be used in the right way. You can't believe how many ways that we can kill cancer cells without harming the rest of the body. It's absolutely unbelievable.
Okay,
But
let's get into
unfortunately,
those then.
when you think cancer is a genetic disease, you're not even listening to what I'm saying.
No.
You're on the constant hunt for genes that don't exist.
Yes, yes. Okay, let's get into those then. So, what are the most promising glutamine inhibitors or glutamine blockers, and what are the most accessible?
Well, this is another great tragedy. The most powerful one is Don 6-deoxynorlucine, which has been kicked around for a long time. It was used on little kids. It was used on cancer patients years ago. It's an antibiotic um, from a staph strep, I think. It was isolated at one point, and they didn't know how to use it. They dumped large doses on these poor cancer patients without targeting the glucose. I mean, if you don't know what you're doing or how you're doing it, then the outcome will never be optimal. So we now know what we need to do with this. Yes. And then the drug companies all come in with their glutamine targeting drugs just so they can make a profit. I said, what are you interested in, the profit or the outcome of the patient? Of course, it's the profit, not the outcome of the patient. So I said, to really manage it, you got to put the patient in nutritional ketosis, then come in with your special drugs and see how it works. But they said, oh, but if we won't know if it's the glucose targeting or our drug that's well. I said, who gives a damn? The patient is going to be the beneficiary of this. Oh no, we can't do that. So the whole system, the structure of the pharmaceutical industry and trying to build their drugs is all screwed up. So you have to come in with the outcome of what's going to be the best for this patient. Can my new drug work effectively with nutritional ketosis and make it better than nutritional ketosis without toxicity? And the answer is the pharmaceutical companies are all over this kind of a concept. It's just that they won't do it with nutritional ketosis until somebody tells them to do that.
Mm,
But that's going to be the future. So yes, there's
okay.
going to be a lot of drugs potentially like the DON. Why is it not available? They said it was too toxic. What are you kidding me? Relative to doxorubicin and all these other things that we have out there. I mean, it's not that should be a prime drug in the drug industry. Is Don should be there, and delivered under nutritional
Mm.
ketosis. You're going to get some tremendous outcome from this.
So a big problem I've come across with people I know who have cancer who are trying to implement this is they can't get done, right? They're
Yeah,
measuring the GKI, all good. They're going through standard of care as well. They
yeah,
can't get done, but yet there's some efficacy in research. I found a good paper on ECGC, found a good paper on berberine. Milk thistle
yeah.
show potential
Yeah.
as effective glutamine blockers. Are these viable options for people who can't find DOM?
Well, they're not going to harm, and in some cases they do help, but they're minor. They're not the big dog. They're not
Mm.
the big stick. Why are you not allowed to use the big stick? Why? Yes, berberine and these other things. We have all that in the fleshed out press pulse. These are supplements that could work together with the different options for sure. We don't discourage the use of those what you just mentioned, but some of the parasite medications are even more powerful, and they're also very non-toxic. So the question is how you get all this together. The issue here is, yes, if we had access to Don, which should be, I have no idea why the government, why this, people should be marching in the streets for this stuff. I don't know why the most powerful drugs are not being used, and they're putting this other crap on top of us. It's like, what the hell is going on here? So, but any event, yes. So you have to do the combos. Now the other thing too is many cancer patients start to realize metabolic therapy only after all of their toxic treatments are not working. They say, oh, okay, standard of care in my case didn't work. My tumor is recurring. Sometimes they say there's nothing more we can do. We've done everything. Why did you go in that direction in the first place? The first thing you do is get your body into nutritional ketosis. Don't worry. But this is the thing: lack of knowledge,
Mm.
scientific illiteracy. This is a plague that our species already has. So you're not you and listen. Most people always trust their physician because they're supposed to know. But in the case of cancer, they don't know. Most of them have no clue. Not all of them. Most of them think glucose or eat anything you want to eat. What are you kidding me? These guys
Mm.
don't read the scientific literature. They understand the biology. I mean, this is nuts.
Mm.
But anyway,
It's
so
hard
this
when
is the
you
training.
So
Yeah,
I was
I
going to say
mean,
it's
it's
hard
just
when you
nuts.
go to an oncology ward and it's just full of glucose everywhere. It just seems almost amoral when you're walking around it. Um, so
Yeah.
could you, what is the specific parasite drug? Just before we
Well,
leave
you
that
have
subject.
you have a bunch of them. You have M-bendazole, fenbendazole, ivermectin might work on this case. There's a number of them. Simon Yu from St. Louis, Missouri, has studied a whole bunch of these parasite medications, and people say, well, why are you doing that? And parasite medications target the substrate mitochondrial substrate level phosphorylation, which is the discovery that we made. That how this is a very interesting thing is that the glutamine is fermented in the mitochondria, dumping out succinic acid. So it makes it look like the mitochondria are healthy, but it's not respired; it's fermented. That's the big thing. It's a
Mm.
amino acid fermentation. Let me give you an example. It's unbelievable. If people have heart attacks, and many people do, if he's no longer breathing because his heart stopped, his blood immediately fills up with glucose and glutamine. Correction. His bloodstream fills up with lactic acid and succinic acid as soon as the heart attack happens. Lactic acid is the waste product of substrate level phosphorylation in the glycolysis pathway of the cytoplasm of the cell, because the mitochondria aren't working because there's no oxygen. So pyruvate is reduced to lactate to give us some energy out of the cytoplasm. At the same time, glutamine, the most abundant amino acid in the body, is being fermented very rapidly with succinic acid as the waste product of that fermentation metabolism. So that told us the difference. As soon as you start breathing again, the lactic acid and succinic acid disappear from your bloodstream because your mitochondria are back on track again. Cancer cells are locked into this fermentation metabolism, whether or not oxygen is present in the environment. very clear. These cancer cells have been telling us for decades what is wrong with them. The cancer has been screaming at us, saying, I am living on fermentation. If you take away my fermentation, you will kill me. The
Mm.
cancer cells have been telling us that for decades, and we have chosen not to listen to them.
Well,
Do you
hopefully we're
believe
in a.
this?
It's really interesting. I mean, it's a new rabbit hole for me as of the last 6 months, and it seems bizarre why people aren't coming on. However, your two recent papers, I guess, make a very big contribution in making this more widely accessible and mainstream. Could you tell us about the two recent papers?
Well, they'll make a difference if people actually read them. The problem is the people who should be reading them aren't reading them, so that the status quo continues. The first paper we just published was amino acid and glucose fermentation are driving the dysregulated growth of brain tumor cells. So we used the human and mouse brain cancers, and they're both driven by this fermentation metabolism. And then how did we know glutamine was the one? We interrogated these tumor cells. So we listen to this. You take the cells and you grow them in culture, and you don't let them. You just grow them in saline solution, salt solution, buffered salt solution, and they die. There's no food. The cells are all dead after about 24, 48 hours. And then you just add fuels back one at a time, one amino acid, another, only one, do the experiment. And you find out that when you add the glutamine, boom, these damn cells get all excited. They start living again. So clearly they don't die. Glutamine prevented death. And we went through all the different amino acids. Yes, asparagine. Yes, a little glutamate. Yes, there's a little. But then in vivo, back in the tumor, you have to say, well, what are the fuels that are present in sufficient quantity in the microenvironment that would allow the tumor cell to survive? And it's glutamine. It's abundant everywhere. So yes, tumor cells can burn up a little of these other amino acids, but there's tiny amounts. They'll go through it like real quick, and there's nothing left for them. And then we go through the sugars. Yes, there's mostly glucose, but the sorbol. The sorbose never exists in our body anyway. And then you have a little bit of uridine. Yeah, there's a little bit of uridine in the microenvironment, but again, it's not going to drive the dysregulated growth of these tumor cells. So clearly, we've interrogated what the tumor cells need, and then we go in vivo, and we target the glucose and glutamine simultaneously while these damn tumor cells up and dying. So clearly, we've worked out the science. We just haven't perfected it as effectively as we would want in the clinic. So that again, dosage, timing, and scheduling, unsexy science will ultimately be the strategy perfected for managing cancer in most people.
Okay, and
So
the second paper.
That was our first paper. So that paper follows up on Warburg's studies. Warburg did not know about glutamine fermentation. So the other thing too is we showed that tumor cells consume oxygen avidly, but it's not linked to ATP synthesis through oxidative phosphorylation. It's used for other things, not that. So that led you. If you go into the scientific literature today, many folks will say Warburg was wrong because tumor cells consume oxygen. Even Warburg made the same mistake. He thought oxygen consumption in tumor cells, which was low, was still linked to oxidative phosphorylation. We have shown that is not the case. There's a disconnect. The tumor cells are consuming oxygen, but not for oxidative phosphorylation. It's significant, maybe a little bit, but not a lot. So that was a big discovery. The fact that amino acids can be fermented in the mitochondria, the fact that oxygen consumption is not linked to sufficient ATP synthesis through oxidative phosphorylation now clears up all of the mess that Warburg was struggling with. We also showed that the amount of lactic acid, Warburg pigeonholed himself by being rigid with his quantifications. Rigid quantification, and we have now shown that those rigid quantifications were inaccurate, and this led to a lot of controversy about cancer. Was he correct about the origin of cancer? Absolutely, was he correct? He just didn't have all of the details fleshed out, and this led to an explosion of misinformation and the shift of cancer over to the genetics. So they said, oh, these biochemists don't know what the hell they're doing. There's a lot of fights with Warburg and everything. Now we see all these mutations. So for the last 75 years, we've been chasing genes. And the genes are all downstream epiphenomena of the metabolism of the cancer cell. So that's why we haven't made any advances in this whole cancer field. So
Oh, it's
now
a
we bring
tragedy.
the whole train back on track, clean up the misunderstanding that Warburg and others have had, and now we can move forward with the correct way to manage cancer in a non-toxic way. Yes. So that paper then presents the strongest evidence to say that there's an amino acid fermentation driving these cancers, and they're all the same. All cancers are very similar. They have a damaged mitochondria, and they need glucose and glutamine fermentation to drive the dysregulated growth. Whether it's a brain cancer, colon cancer, breast cancer, melanoma, doesn't make any difference. They all have the same problem. So they're all the same. Yeah, NIH says, oh no, cancer is 100 different diseases. No, it's not. It's a single disease, a metabolic problem. Now, the second major paper, where we have a lot of other co-authors, MDs and PhDs on this paper, discusses how we strategize this whole concept into the clinic. How do we take the basic science of understanding of the problem and now perfect this for a clinical application? So that's step two. Step one is you have rock solid science to say why we're doing this. Step two is manage now bringing it into the clinic and making it work in clinical trials. But right now, people say, "Oh, I can't believe it unless you do a clinical trial." Well, we would love to do a clinical trial. Problem is, nobody's educated to know how to do this. Uh, Dr. Duryea, myself, and a few others can do it, but the vast majority have no clue. What I just told you is unknown to the majority of oncology clinics anywhere on the planet. So you have to train physicians. You have to know how to do this, what I just said, and then you have to select compliant people. You just can't grab guys off the street and say, "Hey, do all this stuff." He won't know what to do, why he's doing it. You've got to get a compliant group of people, and you have to follow them, and prove unambiguously that this is the way you're going to manage cancer. Then all of a sudden it'll explode, and people will be trained, and everybody will know what and how to do to the best of their ability. But this is a work in progress. But we have
Yeah.
the platform. The bedrock is here. We just have to work and move this field forward.
Well, hopefully we can get the message out. Just a few quick fire questions to end us off, if that's all good with you.
Yeah.
The first is: do you believe most diseases are metabolic in nature?
Well, I think that's a very good question. I think a lot of them are, with the exception of rare inherited mutations like cystic fibrosis, Tay-Sachs disease, Huntington's disease. These are gene-driven causes of these are called inborn errors of metabolism and this kind of thing. But most chronic diseases absolutely affect the ability of our cells. They throw us out of metabolic homeostasis. Metabolic homeostasis is driven by the efficiency of the mitochondrial networks within our cells. Entropy, which is the second law of thermodynamics, is ultimately leads to the demise of all of us. We don't live forever. We undergo disorder, and it's the disorder that eventually leads to the shutdown of our entire physiology. And what metabolic therapy does is keeps mitochondria healthy, so that all we do is delay the second law of thermodynamics. We're just simply delaying entropy. Eventually, when we die, and if we die under natural causes, our entire energy system shuts down over a very short period of time. Our network of maintaining ionic gradients across membranes, we reach equilibrium, and when we reach equilibrium, we're dead. That's the natural way we die. But by abusing our metabolism, we put ourselves at risk for elevated or increased entropy, second law, and we die sooner. Or if they try to keep us alive, we live longer in a very unhealthy state. So you like to live as long as you possibly can. And listen, I'm telling people they can't eat sweets and eat pizza and drink Coca-Cola and whiskey and beer and all the stuff that we enjoy in our lives. But I just think we have to be cautious that a chronic abuse of our body will Well, Mother Nature will let us know in no uncertain terms, and the mitochondrial network will let us know in no uncertain terms what what we need to do. But you also have to realize the body is an incredible healing machine. If you allow it to get back on track, you can deal with a lot of these things. That's why therapeutic fasting, water only fasting, was always considered a way to reset the metabolic thermostat in your body. So there's a lot of ways we can do this if we are knowledgeable to know how to do this. The problem is you need to have this understanding.
Yes, there's a lot of foundational knowledge needed. So, with that in mind, would the press pulse protocol be a viable implementation, or lack of a better word, would it be a viable protocol to mitigate against other chronic diseases or help manage other chronic diseases?
Well, I think for type 2 diabetes, for sure, because there's clear evidence that type 2 diabetes can be cured with diet and exercise alone. You don't need all these other, but of course, people don't want to do that, so they love to take whatever those drugs are that make you get rid of the diabetes. I don't know what the long-term consequences of that. Now, for Alzheimer's disease, I would say 40 to 50% of all, maybe even more, Alzheimer's is the result of damage to mitochondria in your neurons. The problem, of course, with Alzheimer's disease, when your neurons die, you don't make new neurons, so you don't regenerate new neurons. And if you do, they're blank slates. There's no memory associated with that. So again, Alzheimer's disease could be prevented or delayed for sure. Type 2 diabetes could be cured. A lot of cardiovascular disease could definitely be eliminated. Cancer for sure. All the chronic diseases have a linkage to destabilized energetic homeostasis, which is basically mitochondrial function.
Okay, well, that's a very hopeful message. Well, question quickly from me. Last question from me, because I appreciate we've got to go in time, is what contrarian belief do you believe within your field of mitochondria as a metabolic disease, cancer as a metabolic mitochondrial disease? What contrarian belief do you believe that other people in your specific field would disagree with you
on? Well, I think we'd have to discuss that first and find out what part of the disagreement is there. Like what would they disagree about? Because the work of the late Richard Veitch clearly showed the bioenergetic capacity of the ketone body and how it can enhance mitochondrial function. I mean, the discussion about cancer as a genetic disease, I think any rational mind looking at the data would have to agree that it can't be a genetic disease based on the information that I gave you. But scientific debates and discussion are absolutely essential for fleshing out disagreements. Not only disagreements, interpretation of data. How you design an experiment and interpret the data, because we can have the facts. The facts are, this is what develops theories in the sense of understanding. It's how you interpret the facts of the data that you collect from designed experiments. And at first there might be controversy as to how you interpret the facts, but we don't deny the fact. We just have disagreements on how we interpret the facts, and that's how science moves forward. We have to have a consensus on how we interpret the facts that we collect, and that's how we move fields forward. So there's always a disagreement on how we interpret the facts, but that's okay. That's normal. That's a normal process of science, and that's how the fields move forward. When we all come to a better understanding of how we interpret the facts and act upon them. So, but yeah, I mean, I have debates with people, discussions with people, and we come to a consensus. And there's some things that I miss myself, and I said, yeah, that's a very excellent point. We should incorporate that and look more into it. So yeah, that's the way the field moves forward that way.
If only people would be more willing to change their mind, right? More in the spirit of Darwin, like kill your best loved ideas when the facts disagree, right?
Yeah, well, I mean, we can all disagree, but eventually we come to realize, I mean, look at the disagreement that they had about the geocentric, heliocentric movement of the planets. I mean, for 1,800 years, people thought the sun revolved around the Earth and the planets all revolved around. Copernican idea was met with great hostility. So it takes time for the field to come to recognizing the facts of things.
Let's see, the time discovers truth, right? So very hopeful. Dr. Seyfried, thank you so much for that episode. It was really, really wonderful. Before you go, I'd love to just give you an opportunity to for where our listeners can find more of your work. I know your Twitter is good for keeping up with your papers. Any other resources which might be helpful would be beneficial as well.
Yeah, so that's a very good point. And I don't forget, I've written only one book, Cancer is a Metabolic Disease. I did not write these summaries that my name is attached to. People should know that. They come out and they say, oh, I read your summary. I didn't write a summary. They put my name on these summaries, make it look like I wrote it. I didn't write that. I only wrote one book in the John Wiley Press. And I apologize for how expensive it is. I try to tell them, please don't make it so expensive, but they don't listen. So they're a textbook, and they were also a scientific credibility organization as well. But you have to realize another thing. Our research is supported predominantly by private foundations and philanthropy. We received a very nice grant from United Kingdom Childhood Cancer Foundation that helped us develop therapies for pediatric high-grade gliomas. We're very, very appreciative of the UK for supporting our work in that regard. And then we have other foundations. Travis Foundations of Cancer Metabolic Treatments supports our work. And then people make donations directly to my university, Boston College here in Boston. And they have a cancer fund set up so that folks that want to move this field forward as quickly as possible can make direct donations to the university. There's a place on my website on the biology department where they can go down and donate directly to me through the university. So and then the university sets up a fund to support our research based on philanthropic donations and these other private foundations that support our work. So this is the way it has to move. If you really want to make the difference, it has to be mostly philanthropy, because the strategy that we take is not well received by the major granting agencies. When you say it's a metabolic disease and not a genetic disease, they have a tendency to be a little bit less enthusiastic. But that's okay. It's going to change. It's going to change.
Just on that, how much funding goes to the genetic theory of cancer over a year versus the metabolic theory?
Well, let's look at the NIH the National Cancer Institute. I think like $7 billion, something like this. I would say a good 50% of it is going to chasing genes. So immunotherapies and this kind of stuff, all based on the somatic mutation theory. And it's the same in UK. It's the same in all these different countries. Germany, they're all chasing genes. Not all of them, but that seems to be the strategy. So that's one of the unfortunate things. But they'll all come to know at some point that if you want to avoid cancer and manage it effectively, you're going to have to use a metabolic approach. So yeah, we're very appreciative of those folks. And the other thing that I do is, if you look at the papers that we published, the two papers, you'll see acknowledgments. And you say, who are all these people in the acknowledgement section? They're the folks that are giving us the money. The organizations and the folks that give us money. There are some people, believe it or not, that just want to be part of the movement. And they just want to say, I gave this guy money, and he acknowledged me on the bottom of his paper. Like, you're going to say, who are these names of people and organizations? Well, they're the ones who support our research. And if they'd like us to acknowledge them, I'd be more than happy to include their name as a supportive of this new movement to manage cancer. So some of these guys get excited and say, "Oh, I want to support this. Let me give the money to this." And so you're giving the money to the right organization, the right approach to managing cancer. That's for sure.
Wonderful. Well, what we'll do is we'll put all the links you just described in the show notes, so people can go and donate if they'd like to. We'll put links to your book. We'll put links to your Twitter. And yeah, just from our side, thank you so much. Really, it was a real privilege to sit down with you and learn a load. So thanks for coming on.
Yeah, well, thank you very much. It was a pleasure.